Usually when we talk about a medical diagnosis, there's this expectation of absolute precision, like engineering.
Right.
You break your arm, the X-ray shows that jagged white line, and the doctor just points to the screen and says, there it is. It's broken or it's not.
Exactly. We rely on that visual evidence. I mean, it's comforting to have categories that are strictly binary, right? Things that feel like they're handed down by absolute biological laws.
Yeah, but diving into the stack of sources we have for today's deep dive, we're looking at nursing texts, obstetric research, clinical guidelines on what the medical world calls the stages of labor. And that expectation of precision just completely shatters.
It really does. It's a deeply constructed landscape.
Totally. And the thing that absolutely blew my mind reading through this material, and we're so glad you're here joining us for this, by the way, is that childbirth is this universal, fundamental human process. But the clinical definitions governing it have an incredibly dramatic history.
Oh, dramatic is the right word.
I mean, imagine a woman in labor in 1995 being rushed to emergency surgery for, failing a medical test, while that exact same woman today would be told she's progressing perfectly normally.
Because the rules literally change overnight. So our mission today is to walk you through this timeline from the very first contraction to the critical recovery period.
Right.
We are going to unpack the biology of what is actually happening in the body, debunk some major misconceptions like the idea that labor follows a steady, predictable clock, and understand why these 4 distinct stages are really the ultimate foundation for global nursing and medical practice.
Okay, let's unpack this, because we have to start at the very beginning of the process, which is stage 1. And the most important thing to grasp here is that the 4 stages of labor are defined by physiological endpoints.
Right, they are biological milestones.
Exactly. Opening the cervix, pushing out the baby, delivering the placenta, and then the uterus recovering. They are not defined by a fixed clock time. But reading the history in these texts, doctors spent a very long time acting like they were.
They absolutely did. And the historical misstep here is just one of the most fascinating examples of how medicine evolves.
Yeah.
To set the baseline, stage 1 begins with true labor.
Which is different from, practice labor, right?
Exactly. True labor means regular, progressively intensifying contractions that are actually causing measurable change to the cervix. It's a very distinct process from Braxton-Hicks contractions.
Right, the Braxton-Hicks.
Yeah. Those are the irregular practice spasms a woman might feel for weeks before labor, but they don't mechanically alter the body. So stage 1 officially ends when the cervix reaches 10 centimeters, meaning full dilation.
But the way they used to measure how fast you were supposed to get to that 10-centimeter mark is where things just get wild. I mean, it all goes back to 1954 and this obstetrician named Dr. Emanuel A. Friedman.
Right. So Dr. Friedman tracks cervical dilation over time in about 500 first-time laboring mothers at Columbia University. And he plotted their progress on a graph and produced this very neat S-shaped curve. Based on his specific group of 500 patients, he basically declared a universal biological rule.
Based on just 500 people?
Just those 500. He said a slow latent phase is followed by a steep active phase that kicks in exactly at 4 centimeters of dilation. He even derived expected speed limits from this.
Speed limits for birth.
Literally. He published that first-time mothers should dilate at a rate of about 1.2 centimeters per hour once they hit that 4-centimeter mark.
And if a laboring woman deviated from that strict 1.2 centimeters per hour speed limit, she was diagnosed with abnormal labor or failure to progress. And the texts point out that this diagnosis became one of the leading justifications for performing a C-section for decades.
Decades. Entire generations of women.
I was trying to wrap my head around this, and honestly, it feels a bit like judging modern highway traffic speeds using a map and data from 1950s dirt roads.
That is a perfect analogy. What's fascinating here is that we rarely see this kind of shift.
Well, the most shocking detail I found in the research is looking at who those 500 women actually were. Friedman's 1950s patients were heavily sedated. They were often under what was called twilight sleep, and a massive percentage of them had forceps-assisted deliveries.
Right.
And both heavy sedation and, pulling a baby out with metal tongs artificially alter the natural pace of labor. Yet that deeply flawed, highly specific benchmark ruled hospital wards for half a century.
It's staggering when you think about the surgical consequences of that benchmark. Like I said, entire generations of women subjected to major abdominal surgery just because their bodies weren't adhering to a timeline established by sedated patients in 1954.
Yeah.
And it really took until 2010 for the medical establishment to formally challenge this with modern data. That's when Jun Zhang and colleagues with the Consortium on Safe Labor analyzed over 60,000 contemporary U.S. births.
Wow, 60,000.
Yeah, a data set 120 times larger than Friedman's.
And what they found completely upended the system.
Entirely. The Zhang curve looked completely different. The data showed that in a contemporary, diverse population, active labor often doesn't clearly begin until 6 centimeters of dilation, not 4.
Okay, so a huge shift right there.
Huge. Furthermore, progress before that 6-centimeter mark can be incredibly slow. It can stall and start and be highly variable without being dangerous or pathological to the mother or the fetus.
The impact of that realization is just staggering to me. The text mentioned that in 2014, major medical bodies like ACOG, the American College of Obstetricians and Gynecologists, they formally moved the definition of the start of active labor to 6 centimeters.
Exactly.
You just don't see that very often.
Yeah.
A core textbook clinical definition being formally revised specifically to stop doctors from intervening too early and ultimately reducing the rate of iatrogenic, meaning medically caused, C-sections.
Yeah, the clinical takeaway is profound here. Patience is a medical intervention in itself.
I love that.
But to really appreciate what is happening during this redefined timeline, we need to look at the biological engine. Opening a human cervix to 10 centimeters requires a massive amount of physiological force.
That's exactly where my head went next. Now that we understand the map of stage 1, how does this dilation actually happen? The texts mention things like gravidity and parity, which I understand means how many times a woman has been pregnant versus how many times she has given birth.
Correct.
And those are the strongest predictors of how fast these stages go. But what is physically driving those uterine muscles to pry open the cervix in the first place?
So the entire mechanism is driven by a neuroendocrine loop. It's called the Ferguson reflex.
The Ferguson reflex.
Right. As the fetal head descends into the pelvis, it physically distends or stretches the lower uterine segment, the cervix, and the upper vaginal walls.
Okay.
Now, nerves in those tissues sense that extreme mechanical stretching. They send a rapid signal straight up the spinal cord to the mother's hypothalamus in the brain.
And the brain reacts to that.
Yes. The hypothalamus directs the posterior pituitary gland to release a surge of oxytocin into the bloodstream.
And oxytocin is the hormone that forces the uterine muscle fibers to contract.
Exactly. Endogenous, naturally occurring oxytocin binds to receptors on the uterus, causing a powerful contraction.
All right.
And that contraction pushes the baby further down into the pelvis, which causes more cervical stretching. That extra stretching triggers the brain to release a larger surge of oxytocin, which causes an even stronger contraction, leading to even more stretching.
Wait, so is this sort of like when someone brings a microphone too close to a speaker on a stage?
How do you mean?
Like the mic picks up the ambient sound, amplifies it through the speaker, then the mic picks up that louder sound, amplifies it again, and you get this screeching audio loop that just escalates and gets louder and louder until someone unplugs the system.
The mechanics of your analogy are spot on.
Yes.
Biologically speaking, what you're describing is incredibly rare. Yeah. Almost every system in human biology relies on self-correcting negative feedback loops to maintain equilibrium.
Like sweating when you're hot.
Exactly. Your body's sweating to cool down your temperature. But the Ferguson reflex is one of the very few genuine positive feedback loops in human physiology. It is a self-amplifying cascade expressly designed to escalate in intensity until the stimulus, the baby, is entirely expelled from the body.
Wow. And while this positive feedback loop is raging, which, according to the sources, can take anywhere from 6 to 18 hours for a first-time mother, I was curious how the nurses are tracking it in real time, because they aren't just standing there guessing.
Definitely not.
I saw terms in the clinical guidelines like effacement and station, and frankly, I felt like I was reading a foreign language. What are they actually measuring with those?
It's a great question because we tend to focus entirely on dilation, the 1 to 10 centimeters. But dilation is only one piece of the puzzle. The cervix isn't just a flat door. It's a thick cylindrical structure, almost like the neck of a bottle. So effacement refers to the thinning and shortening of that tissue, and it's measured as a percentage from 0 to 100.
So if 0% effaced is a thick bottleneck, what does 100% effaced look like?
Okay, imagine stretching a thick turtleneck sweater over a bowling ball.
Okay.
Initially, the neck of the sweater is thick and stands up. But as you force the ball through, the fabric of the neck stretches so thin it essentially becomes flesh with the ball itself.
Oh, wow.
That extreme thinning is 100% effacement. The cervix must completely thin out before it can fully dilate.
Okay, that visual helps a lot. And what about station?
Station tracks the physical descent of the baby. Inside the mother's pelvis, there are two bony landmarks called the ischial spines.
Discal spines, got it.
Clinicians use those spines as the 0 point on a map. If the baby's head is above those spines, it's measured in negative centimeters, like -2 or -3.
Still pretty high up.
Exactly. But as the baby descends past the spines and gets closer to birth, the numbers turn positive, +1, +2, all the way to +5 at delivery. Nurses combine all these metrics, dilation, effacement, station, along with the physical consistency and position of the cervix to calculate what is called a Bishop score.
And that score tells them what?
It's a predictive tool to evaluate how ready a body is for that Ferguson reflex to take over.
Okay, that makes sense. And to track all of this over those 18 hours, the sources highlight a tool called the WHO Partigraph. It was originally developed in the 1970s in Rhodesia, which is now Zimbabwe, and it's basically a paper chart that plots these cervical changes against time.
Right. And the brilliance of the partigraph is in its visual simplicity for busy clinical settings.
Yeah, just lines on a graph.
It uses pre-drawn alert and action lines. If a laboring woman's plotted progress drifts across the alert line, it tells the nurse to monitor more closely.
And the action.
If it crosses the action line, it triggers a mandatory clinical response, like transferring the mother to a higher level of care or evaluating for interventions. It's a direct, highly practical descendant of the curves we discussed earlier, designed to catch complications before they become emergencies.
Okay, so let's say this self-amplifying positive feedback loop of stage 1 has done its job. The cervix is 100% effaced, it's 10 centimeters dilated, the tissue is essentially gone, and the baby has descended into the positive stations. We're officially in stage 2.
Stage 2. Yeah.
And reading the text, it seems like the entire physiological goal completely shifts here. It goes from a neuroendocrine process of forcing a door open to a purely mechanical process of navigating an object through a very specific bony hallway.
The transition from stage 1 to stage 2 is arguably the most dramatic shift in human physiology. Stage 2 is strictly defined as the time from that full 10-centimeter dilation to the actual delivery of the baby.
Right.
It is physically navigating the maternal pelvis.
And the baby isn't just dropping straight down a smooth tube, right? The texts outline this complex sequence called the cardinal movements of labor, but they just list them out. What is actually happening physically?
Well, think of the human pelvis as a curved, bony maze that changes shape.
Changes shape.
Yeah, the inlet, or the top of the pelvis, is wider side to side, but the outlet, the bottom of the pelvis, is wider front to back, and the baby's head is an oval.
Ah, so the shapes don't line up at first.
Exactly. To get an oval through a passageway that shifts its orientation by 90 degrees, the baby has to execute a precise sequence of twists and turns. These are the cardinal movements.
So it's literally an evolutionary lock and key mechanism.
Precisely. First, the baby must engage and descend. Then, it undergoes flexion, tucking its chin firmly to its chest to present the absolute smallest diameter of its skull to the pelvis.
Right, getting as compact as possible.
Yes. As it descends further into that changing pelvic shape, it must internally rotate, essentially turning its head to face the mother's spine. Once under the pubic bone, the baby extends its neck to navigate the curve of the birth canal. Finally, after the head is born, it must externally rotate, called restitution, untwisting its neck, so the broad shoulders can align with the widest part of the pelvic outlet for final expulsion.
Hearing the physics of that makes the clinical debate around pushing make so much more sense.
Mm-hmm.
Because stage 2 is divided into phases, right?
Yes, it is.
The texts talk about a passive phase, often called laboring down, where the fetus is descending through that maze, but the mother has no active urge to push. And then an active phase, where maternal pushing is synchronized with the contractions. Here's where it gets really interesting for me, and I want to push back on a huge misconception I held before reading this material.
Oh, what's that?
I always assumed the urge to push was just a psychological reaction to the pain. Like your body hurts, you feel pressure, so you actively strain to get the source of the pain out.
A lot of people think that.
Right. But the research explicitly states that pushing isn't just a psychological response at all.
No, you've hit on one of the most common misunderstandings about human birth. The overwhelming, uncontrollable urge to push is not a conscious decision born out of discomfort. It is the Ferguson reflex arc reaching its absolute zenith.
Wow.
As the baby's head crowns and heavily distends the lower vagina and the perineal floor, those stretch receptors fire so intensely that the subsequent oxytocin surges command the abdominal muscles and the diaphragm to bear down involuntarily.
Just completely taking over.
It is a profound neuroendocrine imperative.
Which explains why women describe it as an unstoppable force. And just like we saw in stage 1 with the timeline debates, there are massive debates about the timeline of stage 2, especially regarding medical interventions.
The historical approach to stage 2 was defined by strict, short time limits. If a woman had been pushing for 2 hours, traditional teaching dictated immediate intervention.
Using a vacuum or forceps.
Yes, a vacuum extractor, forceps, or rushing to a C-section to just pull the baby out of the maze.
Going back to that 1950s mindset of the clock ruling the biology.
Exactly. But contemporary guidelines are stepping back from the clock. They are shifting toward allowing much more permissive time limits, especially for first-time mothers. We now understand that variables like epidural analgesia can significantly lengthen stage 2.
Why is that?
Well, epidurals numb the stretch receptors in the pelvic floor, which dampens the Ferguson reflex, meaning the urge to push is delayed or diminished.
Oh, that makes total sense. The feedback loop gets interrupted.
Right. And modern medicine is learning to accommodate that physiology. As long as the continuous fetal heart rate monitoring shows the baby is tolerating the descent without distress, doctors are giving the lock-and-key mechanism the time it needs to work, rather than rushing to the operating room.
It is genuinely a relief to see clinical patients being codified into the protocols. So the baby has successfully navigated the twists of the pelvis, the cardinal movements are complete, and the baby has arrived.
The main event.
Right. In my mind, and probably in most people's minds, the dramatic part is over. The room breathes a sigh of relief. But reading the nursing texts, the tone shifts completely here. From a clinical perspective, the highest risk of mortality actually begins after the main event.
The clinical vigilance has to remain incredibly high because the physiological danger is far from over. We are now entering stage 3 and stage 4.
Okay.
Stage 3 covers the delivery of the placenta, the organ that sustained the baby, and that normally detaches and is expelled within 5 to 30 minutes post-birth.
I was reading about how they monitor this, and I saw these two terms. The Schultz mechanism and the Duncan mechanism. What is actually happening inside the uterus to detach this organ, and why does it matter which way it comes out?
So the placenta is deeply attached to the uterine wall. It shares massive vascular connections. When it's time for it to detach, it can peel off in 2 primary ways, named after the physicians who first categorized them.
Got it.
The Schultz mechanism is the most common. It means the placenta separates from the center first. Imagine an umbrella closing inward.
Okay, an umbrella closing.
Because it detaches centrally, the bleeding is trapped behind the placenta until the whole organ is delivered. The fetal shiny surface presents first, so clinicians often call it the shiny Schultz.
Add a Duncan.
The Duncan mechanism means it separates from the outer edges first. Because the edges peel away, maternal blood escapes continuously during the separation.
So it's messier.
Right. The rough maternal side of the organ presents first, earning the nickname the Dirty Duncan.
Shiny Schultz and Dirty Duncan.
Exactly. Clinicians watch for these mechanisms along with classic signs of detachment. They look for a sudden gush of dark blood, the lengthening of the visible umbilical cord, and the uterus rising in the abdomen and becoming firm and globular.
I think the text called that Calkin sign.
Yes, Calkin.
Good to know they have specific visual cues to rely on. But once the placenta is out, we enter stage 4, the recovery period. This covers roughly the first 1 to 4 hours postpartum. The uterus begins a process called involution, meaning it's contracting back down to its non-pregnant size. But this is the window where the danger really spikes, right?
It is the most critical window for maternal survival. Postpartum hemorrhage, which is catastrophic rapid bleeding, is the leading cause of maternal death worldwide. And it most commonly happens right here in stage 4, usually due to a condition called uterine atony.
What causes that? Why does it just start bleeding?
Think about the physics of the placenta detaching. When it peels off the uterine wall, it leaves behind an open wound the size of a dinner plate,
Oh, wow.
with massive, exposed blood vessels pumping maternal blood. There is no bandage you can apply. The only physiological mechanism the body has to stop a woman from bleeding to death is for the muscle fibers of the uterus to crisscross and clamp down fiercely, acting as a biological tourniquet on those open vessels.
A biological tourniquet.
Yes. If the uterine muscle is exhausted from a long labor, which is what uterine atony means, a lack of muscle tone, it fails to clamp down. The vessels remain open and severe hemorrhage can occur in a matter of minutes.
So what does this all mean for how childbirth is managed? Because if birth is this deeply natural process shaped by millions of years of evolution, I was surprised to read about a massive global public health push for active management, which specifically means injecting synthetic oxytocin or pitocin during stage 3.
It's a very fair question.
Right. If the Ferguson reflex was so perfectly designed to get the baby out naturally, why do we suddenly need to intervene with synthetic drugs to get the placenta out and stop the bleeding? Doesn't the body know what to do?
It's an excellent challenge, and if we connect this to the bigger picture, it sits at the heart of a major global health debate. At an individual level, some midwifery models do favor a physiologic or expectant approach, letting the body's natural oxytocin slowly detach the placenta without medication.
Which makes intuitive sense.
It does, but you have to look at the data from a population scale. Routine active management is heavily championed by the World Health Organization. This protocol involves giving a prophylactic injection of oxytocin immediately after the baby is born, applying controlled cord traction to guide the placenta out, and vigorously massaging the uterus to stimulate those muscle fibers.
And they recommend this universally, regardless of how natural the birth was.
Universally. Because when you analyze global health outcomes, especially in resource-limited settings where blood transfusions aren't readily available, postpartum hemorrhage is a rapid, silent killer.
Yeah.
A body's natural physiology might work 90% of the time, but at a population level, that 10% failure rate equals hundreds of thousands of deaths. Administering a simple, low-cost dose of synthetic oxytocin to force that uterus to contract firmly and immediately is one of the most cost-effective, high-impact interventions in all of modern medicine.
It's a genuine case where an unglamorous routine protocol during the quietest stage of labor has an outsized, life-saving impact on a global scale. It really reframes the whole experience for me.
Yeah.
It's not just something that happens to you. It is this wildly complex, active biological machine. So to recap the journey we've just been on through these sources, the 4 stages map perfectly to 3 distinct mechanical tasks plus a critical recovery phase.
Right.
Stage 1 is the neuroendocrine process of opening the cervix, driven by the escalating positive feedback loop of the Ferguson reflex. Stage 2 is the purely mechanical navigation of the fetal oval through the shifting bony maze of the pelvis via the cardinal movements. Stage 3 is the detachment and expulsion of the placenta. And stage 4 is the vital biological tourniquet of uterine involution to prevent hemorrhage.
That's a perfect summary.
We've seen how understanding the actual biology is leading modern medicine away from strict clocks, and how sheer nursing vigilance in that quiet 4th stage genuinely saves lives.
The complexity of the system is just awe-inspiring. But for me, the lingering takeaway from these texts goes back to our earlier discussion of Dr. Friedman and Dr. Zhang. We saw how a fundamental biological rule, the expected start and speed of active human labor, turned out to be an accidental artifact of 1950s hospital practices. It wasn't human nature at all. It was a reflection of sedated patients with forceps deliveries being recorded as normal.
Which is still so crazy to me.
It really leaves you with a profound question to consider as you go forward. What other fixed medical definitions or expected timelines in our bottles, things we accept as absolute biological facts today, are actually just reflections of the specific flawed populations we chose to study decades ago?
That is a phenomenal question to end on. Are we still judging our health by 1950s dirt roads when we should be looking at modern data? It challenges us to look past the surface of any diagnosis, to realize that medicine is an evolving landscape, not just a binary black and white X-ray. Thank you so much for joining us on this deep dive. Keep asking questions, keep challenging the definitions you are handed, and we will see you next time.